Hello everyone, my name is Reggie. I am a therapist in Florida. I got my master's degree in mental health counseling. I have been studying for the National Clinical Mental Health Counseling Exam. This is my study guide video for the National Clinical Mental Health Counseling Exam. I have been studying this for like the last 2 years, so this is truly just a study guide of this material. If you work in any field of mental health, the exam is not 100% true to life to what you do because you only work with a certain demographic of clients. But for the exam, you kind of have to know everything under the umbrella, and here we are. This video is for educational purposes only. I encourage you to do your own research. But again, I have been studying this for the last 2 years, so I am just going to get into it now. My notes in the beginning of my study guide, I realize that are a little fragmented, meaning it's just a piece of information. So I'm going to do my best to flesh it out and give some context so it's not just fact. Cool. This video might be long and drawn out, but if you've been studying for the exam, you know that it's a lot of material, and here we go. All right, so just jumping into it. I put this in the first thing in my notes. I don't think you should give a lot of thought to this, but F codes, be familiar with F codes. Not necessarily just know them like the back of your hand, but more so in the sake of diagnosing. There's different F codes in terms of like addiction, like actively addicted or like in remission, that kind of thing. So maybe not necessarily focus on the F codes, but the actual state of their diagnosis kind of thing. Next up, CBT thought record, cognitive behavioral therapy thought record. What's the order? There's a couple different versions if you Google it, but they all kind of have the same order. And this is the one from my study guide that I've been studying that it gives this order. Event, emotion rating, thought, challenging thoughts, new emotion rating. For example, you lose your job or somebody loses their job, the emotion rating or their emotion. I'm so upset I lost my job. What's the emotion rating? 90% or 100%. I'm so pissed off I lost my job. The thought, I sucked at that job. Challenging thought, I can get a new job. New thought, it's challenging the thoughts. I'm a good employee or I'm a good worker. I know I can get a new thought. I know I can get a new job. New emotion rating, 90%. I feel confident I can get a new job. So that was my hypothetical in that situation. But again, let me just read the order. Event, emotion rating, thought, challenging thoughts, new emotion rating. Moving on. Eliminate SI, eliminate suicidal ideation. So, for example, if a client has SI and they're also actively in addiction, what's more important, eliminating their SI or making sure they get off drugs as soon as possible? And the answer is eliminating SI. At any turn, if somebody has SI, you want to eliminate the SI. Not reduce, not, manage it, eliminate. Eliminate suicidal ideation. Next up, here and now functioning is more important than ADLs. Here and now equals the interpersonal mindfulness, the dynamic between therapist and client. One's raw thoughts and what's happening in their personal life will emerge in therapy. Here and now is more important than ADLs. This is just from a question that I had, and what's more important, they're doing their ADLs or just like their here and now functioning, and here and now functioning is more important. ODD is characterized by a pattern of angry or irritable mood. This is just a definition. ODD is characterized by a pattern of angry or irritable mood, argumentative or defiant behavior, or vindictiveness lasting at least 6 months. That's important, 6 months, as evidenced by at least 4 symptoms from any of these categories. And I'm not going to explore that any further. I would want you to go into the DSM and look up the symptoms that they have to qualify for ODD. But again, ODD is characterized by a pattern of angry or irritable mood, argumentative or defiant behavior, or vindictiveness lasting at least 6 months as evidenced by, and you will go into those categories. I had a client during my internship who was 15, 14. I just wanted to choke him through the screen because he had ODD. And, I said hot, he said cold. And it was just one of those things we were going back and forward. And it was like wrestling a bear. But I realized that, after months and months and months of dealing with this client, we finally opened up that, he finally opened up that there was some sexual abuse back in the day. And he just never knew how to process it, But on the outside, he was angry, irritable, argumentative, defiant behavior, and had vindictiveness. He was just such a jerk. Moving on. ADHD plus ODD, identified behaviors causing difficulties and list consequences of problem behaviors. Why did I write that? Again, my early notes are very just facts, so I'm going to do my best to kind of give context to that. ADHD plus ODD, identified behaviors causing difficulties and list consequences of problem behaviors. I'm going to move on from there. If you have a client who is in harm, either they are causing harm to somebody else or somebody's causing harm to them, you want them, and this is the part of the note, to comply with crisis safety plannings. Somebody's in harm, doing harm, you want to make up a safety plan, and you want them to comply with that crisis or safety plan. Next up, gently redirect the client to focus on her own emotional concerns. Counselors must facilitate the therapeutic relationship while working objectively. The context for this is that there's a client who is dealing with bulimia, if I'm not mistaken, and they are just so wanting their husband to be like, do you like me? Do you like me? Do you like me? Kind of thing. And the questions were like, what should a counselor focus on? Like, the wife's opinion on the husband. And the answer ultimately is focusing on their own emotional concerns. So, moving on. Adults, and this is the next question with body dysmorphic disorder. Adults with body dysmorphic disorder exhibit high rates of suicidal ideation and suicide attempts. You can administer the Columbia Suicide Severity Rating Scale, or the CSSRS. That's all in a lot of questions too, in terms of like suicide, what assessment do you use? And more often than not, it's the Columbia Suicide Severity Rating Scale. All right. Standard treatment for body dysmorphia includes cognitive behavioral therapy and medication, typically SSRIs. You want to refer to a psychiatrist or psychiatric nurse practitioner. That would be the most appropriate referral for a client that's dealing with body dysmorphic disorder. Psychiatric medical evaluation. All right, substance-related disorders commonly occur with body dysmorphic disorder. The client mentioned alcohol as their drug of choice, so you can administer the Michigan Alcoholism Screening Test, and it's the most important intervention for this client at this time. So again, substance-related disorders are common with people who have body dysmorphic disorder. So if a client is mentioning that their drug of choice is alcohol, you can administer the Michigan Alcoholism Screening Test. Moving on. Using alcohol to numb or dull one's emotion is not a criterion for a diagnosis of alcohol use disorder. Again, using alcohol to numb or dull one's emotions is not a criterion for a diagnosis of alcohol use disorder. Counselors are required to discuss the limits of confidentiality with all clients prior to counseling. Moving on, self-explanatory. To help you determine the level of care your client needs in the treatment goals, you can use the Minnesota Multiphasic Personality Inventory 2. Again, Minnesota Multiphasic Personality Inventory 2, MMPI2. This is in a lot of questions that I had in my practice exams. Minnesota Multiphasic Personality Inventory 2 can help you determine the level of care your client needs in treatment goals. I'll just leave it at that because there's another question that's similar, and it's not about treatment goals. It's about like their diagnosis. So I don't want to confuse that, but in terms of like just figuring out who the client is and the level of treatment that they need, the Minnesota Multiphasic Personality Inventory 2 is one of the best assessments that you can use. FYI, CBT focuses on core beliefs that the individual holds and which may impact their emotional well-being. So just know that, like, CBT is core beliefs. Got it? Good. Reactive attachment is a trauma stressor related disorder often seen in children. It's plain and simple. Reactive attachment is a trauma stressor related disorder often seen in children. Behavioral experiments are a CBT intervention that the client can use at school and work to determine whether his beliefs or predictions about his ability to make friends and that others have no time to socialize are true, or whether these predictions keep him isolated. So this is a client that's just in college, and they're working a lot, and they're kind of I think they have social anxiety. So it was like, what type of CBT intervention can the client use to make new friends? And the answer was behavioral experiments. Motivational interviewing, or MI, is a counseling approach often used with clients who are ambivalent about change, but are mandated to counseling by family or the courts. MI helps the client determine whether changes can help them get what they want. Can determine what changes can help the client get what they want and what steps they could take to make those changes. It's an effective approach for substance addiction, particularly with clients when clients do not recognize their substance issues. It is less insight-oriented and focused on resolving ambivalence and resistance. A big thing with MI is figuring out people's goals, their motivation for change, and you can kind of use that as leverage throughout the process to get them to change their ambivalence, like get them towards their goal. Can't you see how this is not getting you towards your goal of? So it's less insight and more just like, okay, let's get over this on being on the fence. All right, moving on to some personality disorders, it looks like. All right, borderline BPD presents with patterns of instability in interpersonal relationships. It's huge. Patterns of instability in interpersonal relationships and self-image such that the individual frantically attempts to avoid abandonment, alternates between idealizing and devaluing persons, demonstrates impulsivity and potentially self-harming activities, recurrent suicidal threats or behaviors, and inappropriate intense anger or difficulty controlling one's temper. If you don't call me back, I'm going to kill myself. Like, these are borderline people, you know. They need you, they love you, they hate you. They're just like, it's you know, it's a lot. It's borderline. Antisocial clients with ASD, antisocial disorder, show some similar traits related to disregard for safety or of self or others, but also demonstrate a lack of remorse for hurting others, as well as lying or conning others to get what they want. Antisocial are like the psychopaths. Like, these people will kill you in cold blood, not think twice about it. Like, it's just like no feelings involved. Dependent personality disorder. People with DPD rely on others to tell them how they should feel and have difficulty making different everyday decisions without someone telling them what to do. Should I wear this or this? This or this? No, I need you to pay attention. Which one should I wear? This or this? Those people. Should I go here or go here? Should I do this or do that? They can't make their own decisions. Histrionic personality disorder. Those with HPD tend to use sexually provocative behavior when interacting with others and are deeply uncomfortable when they are not the center of attention. Very sexual, very look at me. Okay, clients with borderline must learn to manage and tolerate distress at these situations and emotions and push them towards Clients with BPD must learn to manage and tolerate distress as these situations and emotions push them towards frantic, inappropriate behaviors geared to relieving the immediate distress without insight into the consequences of their actions on self and relationship with others. DBT, dialectical behavior therapy, helps those with BPD. That was a question, like, for somebody with BPD, what's the best therapy type that you can use with them? And it's DBT, dialectical behavioral therapy. Interpersonal growth groups for individuals with BPD are helpful as they recreate their interpersonal relationships within the group and receive feedback on how their interactions impact others. Skill-building groups are often used in combination with individual therapy when applying a dialectical behavior approach for BPD. Family therapy sessions have been shown to have some value in working with clients experiencing BPD, as it helps the family to understand the obstacles the client faces and helps the family and client develop strategies for working with BPD. The main cause of BPD is childhood trauma and unhealthy family relationships. I have that highlighted, so that is why I use my hands to say that. The main cause of BPD is childhood trauma and unhealthy family relationships. A family genogram, whether using CBT or DBT for treatment, can help facilitate the client's understanding of historical patterns that have shaped his or her personality. Clients with substance addiction are prone to denying the extent that their substance abuse causes themselves or others. Substance abuse therapy groups focus specifically on participants' addiction, and the group model permits greater opportunities for participants to challenge members who minimize the effects of their addiction. A substance abuse treatment group allows the client to begin working on addiction outside of individual therapy and preserving that counselor-client relationship. This is super important. I have I have multiple clients that have substance abuse issues, and I am a therapist. I am not an addiction therapist, so I often recommend my clients to go to NA, go to a group, and to not minimize how it's affecting you, right? So groups kind of like put you on the spot, so to speak. In therapy, clients can just kind of mask and not tell you the whole truth and not really be forthcoming. But if you're in a group with people who are all dealing with it and sponsors, they can call you out and be like, dude, stop playing, bro. Like you're playing, you know what I mean? So groups help clients who are struggling with social substance abuse. Clients with BPD tend to experience more distress in young adulthood, but may gradually experience fewer symptoms in late adulthood, and this can be improved with treatment. Therapy is frequently long-term and may be needed for years to modify ingrained personality characteristics. Skill building with DBT is an effective treatment, and some studies show that clients may not qualify for a BPD diagnosis after completing long-term DBT therapy. Let me say that last sentence again because the acronyms just sound so similar. Skill building with DBT is an effective treatment, and some studies show that clients may not qualify for a BPD diagnosis after completing long-term DBT therapy. BPD, DBT. Adults with parental figures who were inconsistently available or rejecting or violated normal boundaries tend to be anxious and insecure, ruminate about relationships, and may be dependent or needy, which is also ambivalent. Adults with secure attachments create meaningful relationships and set healthy boundaries. Those with avoidant attachment styles tend to avoid closeness or connection and may be perceived as rigid, critical, and intolerant. Individuals with a disorganized attachment style are chronically vulnerable and tend to dissociate when triggered by perceived threats. For clients that struggle with ambivalent attachment, congruence will be the utmost importance in working with him or her or them. Those with ambivalent attachment experience inconsistency from parental figures during childhood, never knowing if they would experience emotional availability or rejection. Congruence demonstrates authenticity or consistency between the counselor's internal and external self. So you just got to be yourself 100%, basically. Individuals exist in systems, and systems theory states that when one member of the system changes, this causes distress for other members of the system as they respond to the change. The The client's changes are helpful for him or her, but create dissonance for his husband in this particular example. So let me start that again. The client's changes are helpful for him, but create dissonance for his husband when the client is not responding as he usually does. Providing education on change and its impact on the family systems allow the client to understand current circumstances and may help him respond with empathy to his partner as they navigate changes. When working with couples, the counselor's policy of holding or not holding secrets must be determined and communicated to the couple in the informed consent. Many counselors choose to not to hold secrets for individuals in a couple so as to not become triangulated in the relationship. And triangulation is very unhealthy communication. Tell him that he is mean to me. Well, you tell her that she needs to do this more, and I won't be so mean. So that's triangulation. It's very unhealthy communication. You don't want to be in the middle. You don't want to be in the middle of that. Counseling is strengths-based. Counseling is a strengths-based helping profession in which counselors assess and draw attention to the strengths that clients bring into counseling. This increases hope for change and encourages the client to see themselves as capable of making changes. Straight up sentence. Identifying which areas the client struggles with and asking for help will guide the counselor and client to focus on the emotions that surround these specific situations. This allows the client and her partner to be aware that these trouble spots are important and need more attention when communicating. The counselor and client then can practice role-playing examples of these situations. Straightforward, very straightforward. Empathic attunement is a counselor's awareness of the client's emotional, somatic, and behavioral rhythms through tracking moment-to-moment changes and building a therapeutic connection, demonstrating congruence and understanding. Attunement requires the counselors to emotionally engage with the client and their story and is the foundation of a therapeutic relationship. Like just being there for them, being on being on your game, like not zoning out, like when they're talking, noticing the subtle shifts in their being, Empathic attunement. More DBT. Dialectical behavioral therapy groups are the most widely prescribed treatment for people diagnosed with BPD. I must have another vignette about that, apparently. The individual and group therapy focus on managing emotions and building skills for better relationships. DBT, BPD. BPD, DBT. More BPD. BPD is a personality disorder that centers around the anxiety of being rejected and abandoned, which this client appears to have experienced often in this practice that I did. Because the client shows little insight into himself and his thoughts, emotions, and behaviors, helping him to distinguish between when he doesn't care and when he doesn't actually care, and when he feels too anxious to attempt caring, will help him better understand his feelings. Let me read that last part again. Because this particular client shows little insight into himself and his thoughts, emotions, and behaviors, helping him to distinguish between when he doesn't care and when he doesn't actually care, and when he feels too anxious to attempt to care, will help him better understand his feelings. So more of that DBT. All right. Question of which of these is least. Okay, so this is my bold before reading everything. And a lot of this, in my earlier notes, it's all just facts, and then I get into some questions. So this is a paragraph, so here we go. Question was, which of these is the least helpful? Here we go. Ambivalence results from holding two opposing feelings about a person, thing, or situation. This causes the individual to have difficulty making decisions and knowing which feeling to follow. The anxiety of ambivalence makes it easier for the individual to disregard engaging with his emotions in order to lessen the anxiety. Because of his ambivalence, the client is least likely to follow through with journaling about his emotions outside of sessions, and this would cause him to encounter the duality of emotions that are stressful for him. A better process would be to educate the clients on ambivalence and how it can be normal and healthy, but when it becomes chronic, it can become debilitating. Helping the client name and identify different emotions and how he might know when he experiences them would then be helpful for the client who avoids emotions. Concentrating on where in his body he feels specific emotions will provide him with a way to distinguish which emotion he is feeling in the moment. So this is for somebody who just has low insight and they're on the fence and just don't know where to go. So you're basically educating them on, it's okay to be ambivalent sometimes. When you're ambivalent all the time, then that's debilitating, and we gotta get you moving, buddy. Come on. So journaling is not going to help a client like that because it's only going to put them more in a tailspin and just So education, psychoeducation, basically is the best for a particular client like that. Counselors who work with clients diagnosed with BPD, a lot of BPD questions. Counselors who work with clients diagnosed with BPD are often challenged to set and maintain strong personal and professional boundaries with their clients. The client's personality patterns include frantic efforts to avoid any imagined abandonment, so changes in appointment times, not allowing the client to stay longer than their appointment time, or holding them to therapeutic discussion rather than casual conversation can appear as rejecting the client. Counselors working with this population are challenged to set, explain, and maintain their boundaries, often needing to repeat these to the client or set new boundaries as new circumstances occur with the clients. So it's basically like if you have a client with BPD, they're kind of like when you go bowling and you set up the guardrails, like they need the guardrails apparently, and you got to keep them in, or just explain why the guardrails are there apparently, because if it's let me read that question again. The client's personality patterns include frantic efforts to avoid any imagined abandonment, so changes in appointment time, not allowing the client to stay longer than their appointment time, or holding them to therapeutic discussion rather than casual conversation can appear as rejecting the client. Counselors working with this population are challenged to set, explain, and maintain their boundaries, often needing to repeat these to the clients or set new boundaries as new circumstances occur with the client. So yeah, guardrails for sure. With clients with BPD, it's just like, this is what I'm doing. That's called structuring, and I think that's later in my notes as well. Research has shown that the therapeutic relationship between client and counselor is the most important element in effective counseling. When the client feels safe enough to be themselves, they will, in the therapy room, act in the same ways that they interact with others, which allows the counselors to help them look at their interpersonal styles and skills. Therapeutic relationship is one of those counselor skills questions, and apparently that was the answer. The Personality Assessment Inventory, or the PAI. There's a lot of assessment questions, and some you just got to know. So I don't know them all to break it down like that, but some you just got to know. All right. The Personality Assessment Inventory, or the PAI, assesses personality and psychopathology and shows convergent validity with the Minnesota Multiphasic Personality Inventory 2, to be used on clients with behaviors linked to psychopathology, criminal history, extreme lengths, irritable disposition, etc. Straightforward. Clients in counseling often feel worse before they feel better as they face uncomfortable emotions, thoughts, and behaviors. Very true. It will be important to prepare the client for any increase in negative thoughts and feelings with coping strategies so the negative thoughts and emotions do not lead to negative behaviors. Very, very true. I don't want to expound upon that, but the clients will often feel worse before they feel better because they're unpacking stuff that they haven't unpacked, that they've shoved away for years, so it's got to be there for them and help them with coping strategies, apparently, so the negative thoughts and emotions do not lead to negative behaviors. Individuals with a fragile self-esteem or self-identity, for example, narcissists, have difficulty with insight into their own emotions. Making an observation of what the counselor is observing opens up an opportunity to begin processing emotions with the content. For example, it seemed like it was hard for you to connect with what happened in your life to your feelings about yourself. Several times, and this is insight into this, this is context into a practice test that I was doing in particular client. Several times during her story, when you asked how her behavior impacted her feelings about herself, she looked at you and paused, but then quickly returned to her story. When you asked how this impacted her relationships with her parents, she told you everything is fine. So I'll start from the beginning again. Making an observation of what the counselor is observing opens up an opportunity to begin processing emotions with the content. And it's one of those, like, what would you say? And the answer is, it seemed like it was hard for you to connect with what happened in your life to the feelings about yourself. So you'll have a lot of, like, what would you say? And most of the answers are basically with empathy and open-ended questions. So moving on. Which of the following counseling interventions will be least... This is a straightforward question, and I'm going to give you the answers, apparently, or just the answers. Which of the following counseling interventions will be the least helpful in helping her connect to her story in this particular client? And the answer is therapeutic games, such as the ungame, are often used to help clients begin talking about their feelings. These are usually with children and adolescents, and it would be unusual to do this with an adult with normal intellectual abilities. If you don't know what the ungame is, if you're unfamiliar with it, I've done it with clients before who just are like, they just don't open up, right? So the ungame will ask questions like, what do you want to be when you grow up? You know, what would you do if blah, blah, blah? And it just gets them to talk. But for somebody who has like good cognitive abilities, it's not necessarily the most helpful. So that's what this question is asking and saying. As the client has demonstrated willingness to talk to the counselor about her life history, it would be most beneficial to follow a sequential process of introducing the connections between emotions, thoughts, and behaviors, followed by helping the client identify feelings she's experienced. So if you have a client that has normal cognitive abilities, follow the bouncing ball instead of playing the endgame. Moving on. Which of these core attributes will help the client identify emotions? A non-judgmental stance is the most important core attribute that the counselor will need to employ at this time. This is the answer. The client is just learning to connect emotions and will likely be anxious at trying to explore such uncomfortable material within herself. Active listening and attending skills show the client that the counselor is present and available to them. This is important in all sessions, although listening and attending postures will not indicate acceptance of the client's attempts at identifying emotions, as a non-judgmental stance will do. Reflection of feelings are core skills in which the counselor listens to what a client is saying and allows the counselor to name the feeling that corresponds with or underlies the client's statements. For example, it sounds like you were sad. Because the purpose of this intervention is to have the client connect her actions to feelings, it is not helpful for the counselor to take that role instead. Conflict tolerance is a necessary skill for counselors to possess. However, based on the information presented in that particular vignette, the counselor and client are unlikely to experience conflict in the therapeutic relationship because helping the client identify emotions is done at the client's pace to facilitate a safe and trusting environment. Moving on, I'm not going to dive too much into that because I have to give you would have to have the full context of the vignette, etc. So, moving on. Counselors do not give advice or make suggestions for clients because counseling is client-directed. My supervisor during my internship would have to disagree with that, but for the sake of the exam, counselors cannot be sure that their own advice or suggestions will be effective for the client or in the world outside of the session. If a counselor gives advice or makes suggestions that do not work out well for the client, the therapeutic bond can be ruptured and the client may feel betrayed. So for the sake of the exam, counselors do not give advice. Let's just bite my lip on that one. In considering concurrent treatment for this client, which of the following would be most helpful? And the answer is process-oriented groups focus on here and now relationships between the members of the group. They are longer-term groups where members end up recreating their interactions with others through the process of transference with other members of the group. And I'll definitely explain transfers later. Process-oriented groups allow for members to provide positive and negative feedback to each other to promote personality change and growth. This will be helpful for the client to have others speak directly to her interpersonal interactions with people and how it is received by others. So in counseling, we have to be kind of the good guys. We can't necessarily step on toes. I am somebody who will call out clients. I am somebody that uses confrontation, right? But, again, I'm not somebody who deals 100% with these clients are dealing with. So if they're in a process group with other people who are dealing with that, they can call them out. They can call them out on their BS, So that's basically what this is saying. Process-oriented groups focus on the here and now relationships between the members of the group. All right, I have this in bold, so apparently this is something to pay attention to. Using the information provided, which of the following steps should be taken first? And this is a 16-year-old client. Addressing the parent's thoughts and feelings about needing or choosing to access services, which includes home visits, is critical to building a therapeutic relationship with both client and her parent. Depending on the mother's cultural history and beliefs, having a stranger in the home who's acting as an authority figure may feel demeaning, intrusive, or frightening. Building the therapeutic relationship with the client's mother is equally as important, or guardian, is equally as important as building it with the client. Asking the client and mother if they are willing to work together may be received as a judgment that the mother hasn't been working for her child up to this point and may be perceived as insulting. Setting up initial boundaries for the client and determining whether they should stay with her maternal grandmother or choices made by the client's mother, and the relationship may be too fragile at this first meeting for the counselor to begin making suggestions for parenting. So those remaining options are apparently the incorrect ones. And the correct one was addressing the parent's thoughts and feelings about needing to or choosing to access services, which includes home visits and critical to building a therapeutic relationship with a book client and her parent. This one is like straight up the whole question. So this is a time where I will ask the question. I'm going to pause and I'm going to let you think about what the answer will be, and then I'm going to give the answer. Using the information provided, which action is most appropriate in working with this client? This is the whole thing again. A, helping the client's mother set appropriate guidelines and rules for this client. Okay, so this is the next question. A, helping the client's mother set appropriate guidelines and rules for this client. B, referring the client for testing and possible accommodations due to her academic difficulties. C, obtaining release of information to talk with client's school, physician, and family members. D, assessing the client for early childhood or current traumatic events. So you're probably saying, oh my God, I don't know anything about this client. Like, what are you talking about? How do I answer this? So apparently this is just, you're doing therapy on a minor. You've already set up in the previous question that it's best to set up goals with the client's mom on how to work this out. So using the information provided, which action is most appropriate in working with this client? And this is an important thing too when reading questions. I have been studying for so long, for like 2 years, that I will read questions and like take the first 5 words and run with that and not finish the whole question. For this one, it's like most appropriate. Sometimes there's questions like least appropriate, right? So it's really, really important to get those like key words in the question. Using the information provided, which action is most appropriate in working with this client? A, helping the client's mother set appropriate guidelines and rules for this client. B, referring the client for testing and possible accommodations due to her academic difficulties. C, obtaining release of information to talk with client's school, physician, and family members. Or D, assessing the client for early childhood or current traumatic events. And the answer is a long one. Each of the responses are appropriate. However, the most important will be to obtain a release of information to talk with others involved with working with this client. The intake information is being provided from the mother, and the client appears limited in her responses. The counselor will gain a more holistic view of the client, speaking with the client's teachers to best understand the client and her academic setting, understanding any physical or psychological concerns that may have been previously identified by her physician, and speaking with her grandmother as she is the client's caregiver for part of the week. Based on this discussions with the client's school and physician, testing may be required. It will also be appropriate to assess for trauma, and mother may need assistance with setting appropriate guidelines for this client. However, these will need to occur after more data is gathered from additional sources. And I guess I have more information here about this client. Client is 16 with observable physical retardation and reported learning disabilities. The question is, which assessment is least helpful in diagnosing a client's academic issues? Okay, the options are the Wechsler Adult Intelligence Scale 4, WAIS 4, Wechsler Intelligence Scale for Children V, WISC-V, Kaufman Assessment Battery for Children 2, KABC2, or the Wide Range Achievement Test 5, WRAT-5. And again, with assessments, you kind of just got to know it. And the answer is the WRAT-5 is an achievement test and can be... The WRAT-5 is an achievement test and can be used to determine how the individual is currently functioning in reading, math, spelling, and comprehension. It is used to screen individuals to identify those who need a more comprehensive evaluation. The WAIS-4 and WICSC-V are both intelligence assessments that will identify the client if the client has a deficit in some area of intellectual functioning. The WAIS-4 tests from ages 16 to adult, and the WISC-V test children up to and including the age 16. So both of these will be helpful. These questions about assessments are they're very niche, you have to know. So the client is 16. So if you have one that's from children to 16 and 16 to adult, apparently they're both okay with this client. But you just got to know that, and you just got to know it. So learn your assessments. The KABC-2 tests for both achievement and intelligence and can also help in identifying learning disabilities. So this will be a helpful test for this client. So something, again, that's not good for this client is the WRAT-5. It's an achievement test and can be used to determine how the individual is currently functioning in reading, math, spelling, and comprehension. And the other ones are for intellectual functioning and learning disabilities. So you just got to know it. Moving on. Safety of the client and others is the first level of Maslow's hierarchy and is the priority needed for this family before leaving the intake meeting. All right, moving on. Keep in mind that intellectual challenges, keep in mind the client has intellectual challenges. Which tests will best help determine the client's diagnosis? Oh, you're about to be shook on this one. Hold up. All right, so keep in mind what I said earlier about the Minnesota Multiphasic Personality Inventory 2. That's an option. Rorschach Ink Blot Test, Personality Assessment Inventory, Beck's Depression Inventory 2. All right, so this client has intellectual disabilities, physical retardation, and intellectual challenges. Which test will best help determine the client's diagnosis? And earlier I was like, Minnesota, right? Minnesota Multiphasic Personality Inventory 2, Rorschach Ink Blot Test, Personality Assessment Inventory, Beck's Depression Inventory 2. The answer is the Rorschach Ink Blot Test is used to examine personality characteristics and emotional functioning using a complex interpretation and algorithm that is required for accurate analysis of the client's responses. This test will be the most helpful in determining the client's diagnosis because it does not require extensive reading or reading comprehension as is needed in some long self-reporting tests such as the Minnesota Multiphasic Personality Inventory and the Personality Assessment Inventory, both of which have over 500 questions. The BDI-2 will determine if the client is currently experiencing depression, but will not assess other characteristics or functioning. So again, when I was learning about these inventories, and a lot of these inventories I now do on my clients, but I was looking at the Minnesota, it costs a lot, and it's over 500 questions. That's the whole session, 500 questions. So again, this client has like physical, mental retardation, and intellectual disability. So a Rorschach test is going to be the most, the easiest, the best to determine their diagnosis, because they're not good with sitting still and just reading for a long period of time, or just not intellectually there. So that it wasn't a trick question, but it's one of those things where if you don't have the mental capability to answer 500 questions, then you have to think about these little nuanced things on this exam. All right, I'm setting up the context for this next question. This client has been super sad, doesn't do ADLs or chores, but also has delusions and hallucinations. Which diagnosis is most likely to be accurate for this client? Major depressive disorder, autism spectrum disorder, schizoaffective disorder, bipolar 1 disorder. And I will let you think about that. The client is diagnosed with schizoaffective disorder. She meets the criteria for a major depressive disorder, including sadness, loss of appetite, fatigue, irritability, and psychomotor retardation over the past 2 weeks. Psychomotor retardation, just moving so slowly and just ho-hum, very like ennui from Inside Out, 2. Concurrently, the client has been experiencing delusions and hallucinations for over 1 year during times when she is and is not experiencing depressive episodes. So this one's like a client who lives with their grandma or goes to their grandma's from time to time. The grandma's super religious, and her and her cousins will do like Bloody Mary in the mirror, or she'll see the ghost, things like that. So it's like, so those are delusions and hallucinations. So, and the client is also depressed. So depression versus delusion and hallucinations, schizoaffective. While the client is experiencing a major depressive episode, it is within the context of and better explained by schizoaffective diagnosis. The client exhibits no deficits in communication that are not explained through her IQ scores and does not demonstrate restricted or repetitive patterns, so she does not qualify for autism spectrum disorder. The client does not show symptoms of bipolar 1 disorder, as she has not experienced manic episodes, including pressured speech, psychomotor agitation, racing thoughts, or high-risk activities. Which of the following should be addressed first? And this is the answer. It is important for the counselor and client to explore the roles they each takes in counseling. The client will gain important information from the client by understanding what the client expects the counselor to help him accomplish. So I remember during some intensives in grad school, my professors were like, instead of saying, how can I help you? Or like, what brings you in? It's just like, how can I help you today? Or like, or what brings you in? Say, how can I help you today? So it's like basically establishing, what do you want me to do for you? How can I help you today? What brings you in? I feel like that just negates what I just said, but you basically want to understand what they're there for. And my professors were also like, it is not our job to fix them. It is not our job to fix them. Say it. It's not my job to fix them. So what do you want me to do for you in this session? Versus, don't say it so rudely, but I think you understand that. Which of the following is the best approach to help you determine the client's current readiness for counseling? Answer is, use Prochaska and DeClemente's trans-theoretical model. Prochaska and DeClemente trans-theoretical model includes 5 stages of change and allows the client and counselor to determine the client's current status and their readiness for change, from pre-contemplation to maintenance. This allows the counselor to tailor the treatment plans to the stage in which the client currently resides. Motivational interviewing is an effective way of moving a client into action when they are less motivated to do so or are experiencing resistance. Motivational interviewing is a good intervention to use after the client's stage of change has been determined. after the client stage of change has been determined. So the question was like, which is the best one? And the answer is Prochaska and Clementi's trans-theoretical model of, which is basically the 5 stages of change, or motivational interviewing. And I think on this one I chose motivational interviewing, but apparently it's MI is best used after you understand what stage they're in versus figuring out what stage they're in. And the stages of change made by Prochaska and Clementi is the best option. The counselor will need to develop strong skills in rolling with resistance when using motivational interviewing. The client has stated his resistance to letting others know his use of alcohol, refusal to attend alcohol support groups where he would need to participate, and has twice been prescribed medication for his depressive symptoms and refused to try them. So you as a therapist will have to roll with resistance when it comes to motivational interviewing, right? If somebody is just really being a rock, and I don't mean that in a positive way, and you're just doing everything you can do, perhaps at that point you can refer them out. But in those first 2-3 sessions, you got to roll with them just kind of resisting you, and that will hopefully help them get off of their ambivalence and want to change more. Which of the following circumstances is most likely to negatively impact a counselor's work with this client? If the counselor is in recovery from their own substance history, the client continues to refuse medication for depression, the counselor seeks weekly supervision related to this client, or D, all of the above. You have to be careful with all of the above answers too, and the answer is counselors who have their own history of substance abuse and recovery are often good addiction counselors. But it is also true to some degree all counselors have personal issues that influence their work with clients. It is possible that counselors with a history of recovery may be influenced by and may impose their personal recovery experiences and beliefs on their client. Supervision would be a helpful practice to avoid this potentially negative influence on the counselor's work with the client. Supervision is a good thing. The client's refusal to use medication for depression must be honored by the counselor under one of the ethical principles of counseling, autonomy. So yeah, I work at a social services agency that's right next to a sex health clinic that has doctors and psychiatrists. So I often refer my clients to psychiatrists next door. But if they're like, I don't want to take no medicine, I don't want to do medicine, you have to honor that, even if you know the meds are like going to be a best option for this client. But if they don't want to do it, they don't want to do it, and it's not your job to force them to take meds. A client's determination to be autonomous should not impact a counselor's work with the client, as the counselor should collaborate with the client to find ways to support his decision. So B and C are not negative impacts, and so D is not the correct choice. So all of the above is not the correct choice. And that's what I put originally. I was like, they all are great. But, again, if they don't want to take their own meds, then you got to honor that. Moving on. And a lot of these seem to be questions here on out. So get ready for some questions. Which of the following would be most effective for helping the client be successful in counseling? Reduced down to 2 answers. Oh yeah, I guess this must have been what I did. Reduced down to 2 answers. Review the client's original goals and ask him whether he thinks he's achieving these. Ask the client what he'd hope he'd achieve in the counseling and whether that's changed. Asking the client what he originally hoped to achieve and whether that has changed. That was the answer. Asking the client what he had originally hoped to achieve and whether that has changed allows the client autonomy to determine if his original goals were accurate or if he wishes to make changes to how he can use counseling. Clients frequently come to counseling with one idea in mind and realize that they have other needs that they have not realized. Reviewing the client's original goals and asking him if he's achieving these highlights the power of highlights the power imbalance between counselor and client, and may make the client feel defensive or accountable to the counselor for their actions. Okay, so let me make sure that is comprehensive to you, the audience. Which of the following would be most effective for helping the client be successful in counseling? There's 4 questions, obviously. 2 were just silly, and that's why I didn't include that in this. But the 2 that I reduced them down to: review the client's original goals and ask him whether he thinks he's achieving these, or ask the client what he had hoped to achieve in counseling and whether that has changed. So it's like, what you came here for, do you think you made that? Or ask the client what he had hoped to achieve in counseling and whether that has changed. Interesting. Secondary gains are the conscious or unconscious benefits that individuals get from their current way of responding to life. Secondary gains. So it's like, you may be depressed about somebody's death, so you drink. So drinking alcohol, even though it's not great for you, is a secondary gain. It's like you're getting the gain of numbing yourself, but it's not like helpful. In this case, the client may continue to use ineffective coping skills because it is comfortable or familiar to him, rather than experience the discomfort of change. Secondary gains include the interpersonal or social advantages that an individual may consciously or unconsciously experience because of their own illness, or in the case of the client, in this case, the client's role as the caregiver for his parents and now his wife, so he was drinking a lot. Identifying secondary gains is critical to determining if a client is willing to give these up to meet their stated goals. Secondary gains. Teaching the client about the concepts of boundaries will be helpful for him in setting his own boundaries for self-care and determining what he's able to do for his wife and what he cannot. Learning to set and maintain boundaries will help this client feel less stuck. This is a scenario of a man. He's older and he's caring for his wife, his ailing wife. So he drinks a lot, and to teach him the concept of boundaries will be helpful for him in setting up his own boundaries for self-care and in determining what he's able to do for his wife and what he cannot. Learning to set and maintain boundaries will help the client feel less stuck. Moving on. Persistent depressive disorder versus major depressive disorder. PDD lasts for at least 2 years in adults, 1 in children, characterized by low-grade, continuous depressive mood, some moments of joy, but back to being depressed. So think about Eeyore from Winnie the Pooh. Just constantly, just down, Major depressive disorder, MDD, episodes in severe depression lasting at least 2 weeks. People can have multiple episodes throughout their lives with periods of normal mood in between. PDD individuals can function in their daily life, but constant feeling of gloom, whereas MDD, their daily function can be impaired, profound sadness, hopelessness, loss of interest, suicidal thoughts. So PDD, you can still go to work and make a living. MDD, you're just in bed. You can't do anything. Or should I say daily functioning can be impaired. Profound sadness, hopelessness, loss of interest, and suicidal thoughts. We've got a question. All of the above question. Okay, I got it. That was my note to myself. Which of the following interventions would be the most effective in helping the client learn how his traits impact his relationships with himself or others? And this is a narcissist, apparently. Invite the client to read a book about narcissism. Invite the client to a long-term process group. Invite the client to bring spouse to sessions. All of the above. All of the above interventions are appropriate for a client with narcissistic traits and partial insight. Because the client recognizes his personality characteristics and wants to change, I guess you needed to know that to answer that question. In the vignette, this guy loves his wife and just doesn't have feelings for his family. He just can't feel. He doesn't know that he should feel bad about things. He's doing bad at his job, so he snaps on people what? I'm a good worker. What are you talking about, right? And so he knows that he loves his wife. Most narcissists don't love anyone, so but themselves. So so I'll read the question again. I guess it helps to have context, right? Which of the following interventions would be the most effective in helping this client learn how his traits impact his relationship with himself and others? Invite the client to read a book about narcissism. Invite the client to join a long-term process group. Invite client to bring spouse to sessions. All of the above. The answer is all of the above. All of the above interventions are appropriate for a client with narcissistic traits and partial insight. Because the client recognizes his personality characteristics and wants to create changes, reading about the personality style will help him understand his defenses better and may allow him to view these as defense strategies rather than character flaws. Process groups, unlike psychoeducational groups, help clients work on personality change due to recreating one's relationship in the group through transference. Inviting the client to bring his spouse to sessions will be helpful, as he has described a good relationship which is supportive to him. Including her in sessions is likely to help her be more supportive as she understands his personality better. Next question. Which of the following will be most helpful for the client to initially manage his intense feelings when he hears something that is perceived as criticism? A. Teaching and practicing relaxation exercises with the client during aroused states. B. Exposing the client slowly to greater amounts of negative feedback while in session. C. Work with the client on empathy exercises so he can see others' perspective. Or D. Help client determine when tuning out is appropriate. Answer. Teaching the client and having him practice relaxation exercises is the most appropriate intervention at this time. By implementing relaxation exercises in the moment, he is more likely to not speak or act out of hurt and anger, but will provide himself time to gather his feelings prior to responding. This is a helpful behavioral step initially, and in the future, will be combined with empathy training and self-esteem work to strengthen his own intrapsychic feelings about himself. Prolonged exposure helps an individual to gradually become more comfortable with situations that cause high emotions or anxiety. However, using criticism as exposure to a client with fragile self-esteem will cause greater self-esteem injuries and will threaten the therapeutic relationship. Encouraging one to use a defense mechanism that threatens one's relationship is not an appropriate intervention. Okay, just digesting that for myself. Culture. Okay, so this is really important. Culture includes a client's race, ethnicity, social economic style, family structure, and any group membership that the client is or becomes a part of that influences his or her identity and personality formation. All right, so this vignette, a woman in her 60s, husband died recently. They had land, but now he's gone. The house is falling apart. She's got cars all in the yard that he worked on that he just, never finished. And they used to run a flea market shop. They had a shop at the flea market, so they had a bunch of stuff. And now he's gone. She doesn't want to get rid of anything. She doesn't want to get rid of the cars. House is falling apart. She doesn't want to reach out to help. Like she's, so the daughter-in-law, she has a son who helps kind of cut the grass from time to time. But they had a little falling out because she didn't want her son's hunting dogs to stay on the property. So she's kind of just at the end of her rope, and she's a hoarder, so. But in the vignette, she's a Caucasian woman, heterosexual, like in her 60s. So culture includes a client's race, ethnicity, social economic style. I think she was like only Social Security, minimum money kind of thing. Family structure, she's widow, right? So you have to think about these things. It's really, this exam makes you think critically. You just have to think critically, right? But don't think too hard. And any group membership that the client is or becomes a part of, she doesn't have any memberships that explain, right? So I'm giving the vignette before asking the questions. Hoarding disorders are linked to OCD, OCPD, ADHD, depression, and often begin after a traumatic experience. Her husband died. Bipolar 1 disorder may be linked to clutter during manic phases, but is not generally associated with hoarding disorder. FYI. All right. I'll read that again. Hoarding disorders are often linked to OCD, OCPD, personality disorder, ADHD, depression, and often begin after a traumatic experience. Bipolar 1 disorder may be linked to clutter during manic phases, but is not generally associated with hoarding disorder. Moving on. When considering which assessments are best for a client, their educational level is important. If there are clients that dropped out of high school, this lady dropped out of high school, and she has like an 8th grade reading level. If there are clients that have dropped out of high school or has intellectual challenges, big assessments like the Minnesota Multiphasic Personality Inventory will not be ideal, as it has over 500 questions, and she's at an 8th grade reading level. The BDI-2 measures the client's current level of depression, which is often correlated with symptoms of hoarding. The potential for this client to be experiencing a hoarding disorder is noted in the number of animals she keeps. She has like 30 cats, and the amount of vehicles and other items kept without letting them go. Additionally, hoarding is often related to OCD and ADHD, making the Yale-Brown Obsessive Compulsive Scale, YBOC, and structured interview for adults ADHD tests to consider for this client. So the question was like, which assessment is not the best? And again, like the client who had mental retardation, the Minnesota is not good because you got to have more than high school education apparently, and it's over 500 questions. So if she has an 8th grade reading level in her 60s, like answering 500 questions is like not the best. So it was all the other measures. You can use the BDI-2, you can use the Yale-Brown Obsessive Compulsive Scale, you can use the structure interview for adults with ADHD tests, but not the Minnesota. All right. Same client, new question. Which of the following referrals will be most helpful in treating the client's hoarding disorder? Refer the client to local government services for evaluation of adequate housing. Her house is all falling apart. B. Refer client to refer client to psychiatry for medical evaluation. Refer client to a professional organizer who can help her organize the client's home. Refer client to behavioral health to determine the client's competency for making decisions. Which one do you think it is? Does she need to get local help for housing services? Get med evaluation from a psychiatrist? Have Marie Kondo come in and organize everything? Or get a behavioral health to determine client's competency for making decisions? The answer is referring the client to psychiatry will be the most helpful for treating the client's hoarding disorder due to components of depression, OCD, and ADHD that are often co-occurring with a hoarding disorder. Treatment with SSRIs will be helpful in treating those with a hoarding disorder. Referring to a professional organizer will not be adequate, although once the client has made gains through therapy, teaming a counselor with a professional organizer who is trained with hoarding disorders may be helpful. While hoarding disorders may include difficulty with decision making, the client does not demonstrate incompetence, and referral for evaluation or declaration of incompetence will be inappropriate. Counselors may provide information on local resources for housing, but although the client's housing may not be adequate, at this time, referring her to resources that may condemn and or remove her from her home threatens the therapeutic relationship and dishonors the autonomy of the client to choose where she lives. So I chose the housing one first because it's like, okay, if the roof's falling apart, and she complained when it rained, there's like, water coming in and stuff. So I chose that. I chose like, if the roof is falling apart, you kind of want to get a better place to live, right? But getting her medically stabilized apparently is more important than the roof collapsing on her I guess I have to think about it that way. It just sounds funny saying it out loud that way, I guess. But getting her med stabilized is more important because hoarders, as I might put in different further questions, hoarders have like a psychological connection to the things due to their loss of the loved one or the tragic trauma that they went through recently, So hopefully you learned something on that one. Next question. Which of the following will not be helpful in focusing on change? A. Help the client practice visualizing her home without clutter and yard without clutter. B. Help the client identify strengths that she possesses that can help her make changes. C. Help the client identify barriers to making changes she would like to make. D. Help the client practice relaxation exercises to relieve anxiety. Answer, well, I'll let you think about that for a second. Not helpful in focusing on change. The answer is, helping the client visualize her home and yard without clutter is most likely to cause the client higher anxiety. Hoarding represents an attachment to possessions, and visualizing her possessions gone may upset her. It will be more helpful for the counselor to help the client identify the strengths that she possesses and can draw on as she tries to make changes in the way she thinks about things. Identifying barriers to her success will be helpful as these are areas that can be proactively processed and rehearsed for so that the client has a plan in place when they occur. Again, the answer is not helpful. Using relaxation exercises will be helpful when barriers are encountered, and particularly when the client and her support system begin cleaning and clearing her home and yard. So it's not helpful to get them to imagine it without the things because the things are what they're attached to. Moving on. Common features in hoarding disorders include difficulty making decisions, trouble organizing, procrastination, avoidance, and using objects as replacements for relationships. I hope I had the options there. The options are in this paragraph that I'm reading, but here's the answer to the question that I never read. Having the client bring a small collection of items into session so that the client and counselor can explore the client's emotions and thought processes surrounding items that have little value but take up space in her home is the best thing for her to do. So it's bringing a box of items from your house, empty chair. Empty chair exercise is a helpful intervention to help the clients explore relationships. This client has demonstrated limited insight about her hoarding, making an empty chair exercise difficult. Bring a box of just like a small box of things around the house, empty chair. Giving the clients limited insight into her hoarding, she's not likely to follow through on journaling, so journaling is not a great option or find it helpful. And lastly, asking the client to discard one item a day is not an effective treatment for hoarding disorder, as the difficulty in making decisions about what should go or stay is part of the disorder. So it's like, what's the best option for her? Bringing a box of items around your house, and we can talk about how you feel about it. Empty chair, journaling, or get rid of one thing a day. And it's bringing in the box of stuff, and then we can just talk about how it makes you feel and go from there. PTSD. The criteria for diagnosing PTSD includes the following, and this is just straight up information. This isn't a question. 1, exposure to, so they have to have these items for to be diagnosed for PTSD. 1, exposure to a traumatic event. The individual must have been exposed to a traumatic event involving death, serious injury, or sexual violence, either firsthand or secondhand. They didn't even have to experience it. Like, your neighbor got in a wreck, your neighbor's house burnt down. 2, re-experiencing symptoms. 1 is required. Intrusive memories, flashbacks, or nightmares. One of the 3. Avoidance symptoms. At least one symptom involving avoidance of reminders of the trauma. Birthdays, death days, like when they died, the day they died. Locations, the day somebody else died, obviously. Locations, etc. 4, negative alterations in cognition and mood. At least 2 symptoms. such as negative beliefs about oneself or persistent negative emotions. 5. Alterations in arousal and reactivity. That lists 2 symptoms, including irritability, hypervigilance, sleep disturbances. These symptoms must persist for more than 1 month and cause significant distress or impairment in social, occupational, or other important areas of functioning. This is important because you can think of like adjustment disorder or acute stress disorder, right? But PTSD is more than 1 month, whereas the previous are less than a month. Prior to treating for PTSD, it is important to assess the client's level of dissociation, and each of these assessments will help do this. Most people have some level of dissociation, for example, listening to someone talk but realizing they did not hear a part of what or all of what has been said. However, those who experience traumatic events may experience greater levels of dissociation. In the presence of higher levels of dissociations, individuals with PTSD can experience further traumatic reactions during treatment. And these are some assessments that you can use for your clients with PTSD. Dissociative Experiences Scale 2, DES-2, Multidimensional Inventory of Dissociation, MID, Structured Clinical Interview for DSM, revised, SCID-D-R. There you go. Which of the following treatments would be least helpful for treating a client with PTSD? The answer is trauma-focused CBT. TFCBT is not appropriate treatment for this client because TFCBT is engineered and modeled to be used with children and adolescents who have experienced trauma. So you just got to know these things about assessments. EMDR, brain spotting, and PE are all appropriate treatments for adults with PTSD. Prolonged exposure, PE. Grounding skills are used in PTSD treatment because they help the client keep one foot, for example, part of their mind. They help the client keep 1 foot in the present while they have 1 foot in the past. So it has So it's good to keep a client with PTSD grounded, so that they don't just go there and they're just in the battlefield, or they're there totally away from the session. This allows them to revisit past traumatic memories without dissociating. Having the client focus only on their past experiences instead of keeping part of their mind in the present may cause a dissociative break or extreme emotional outburst that can cause the client further emotional injury. Grounding skills will not help prevent intrusive memories or flashbacks from occurring, but these techniques can help the client who experiences either of these to lessen the disturbance through connecting to where they are in the present. So it doesn't stop the intrusive thoughts, memories, or flashbacks, but it does kind of help lessen the shock value of it. We're like halfway through. There's a lot of context, so there's a lot of information, but hope you guys are finding this helpful. All right. The effects of trauma include the development of persistent negative emotional states, including fear, guilt, anger, etc., which is criterion D.4 for PTSD, and significant alterations in arousal and reactivity, including angry outbursts with little provocation. They're just testy. Testy, which is criterion E.1. As the client's symptoms of PTSD subside, he will be better able to connect with normal emotions of grief and loss. PTSD can be associated with MDD. However, the client has described not feeling sad most days, which is a requirement, criterion A, for MDD diagnosis. This question was one of those funky ones, man. And the answer was this. The limbic system is controlled by hormone release, and as the client works through his anger, hormones that control fight or flight, such as cortisol, will be released less often into the system, inducing normal function, rather than creating new defense mechanism. While crying can certainly be a reaction to trauma, this client has not experienced that reaction and is reporting crying more and more, that he is beginning to feel better and less angry. These facts suggest that crying is not a symptom of PTSD and is occurring as a result of working through his trauma. So this client had a father who died, and tragically, when he was like 11. And every year when the dad's birthday and or death day comes on, he has to be away. He can't be with his girlfriend, and it's ruined relationships for him in the past because he doesn't want to let anybody in. He doesn't want help, with these things. And he's testy. He gets angry like really quickly, and so although it was tricky on this one, it didn't mention anything about flashbacks or nightmares, but it was just the intrusive thoughts. So it's just really tricky. When you think PTSD, you think nightmares, you think flashbacks. But that was a tricky one, and let me go back to the criteria. At least one of the three: intrusive memories. So on his dad's birthday, he had to be alone. So it didn't say intrusive memories, but it's like the dad's birthday's coming up. So you see what I'm saying? So you just have to think critically with this exam, and once you pass, you'll never have to think about this again, but it's helpful depending on what line of work that you do in therapy. And it also said in the vignette, he doesn't cry, and then now he's working on therapy, he's crying a lot more. So, all right. Next question. Which of the following statements would be best to help the client understand his sadness and crying? As the client works on his trauma, he's beginning to show more symptoms of depression. The effects of trauma these are the options. A, as the client works on his trauma, he's beginning to show symptoms of depression. B, the effects of trauma can prevent the client from experiencing normal grief. C, as the client tries to reduce his anger, his limbic system creates new defense mechanisms. Or D, the trauma is a neurological and emotion reaction, and crying is an expected symptom. And it's the one about the limbic system. If you don't know these things about the brain, if you don't know neurology, you wouldn't know these things. You would just know all the things you know about therapy, right? But so let me just read that sentence so it hopefully makes more sense and ties in everything I just said. The limbic system is controlled by hormone release, and as the client works through his anger, hormones that control fight or flight, such as cortisol, will be released less into the system, inducing normal function rather than creating a new defense mechanism. So his defense mechanisms was like getting angry and being alone, and so the limbic system was releasing so much fight or flight for him that he just couldn't even process his emotions. But now that he's working through it, there's less fight or flight, and he actually can just experience normal grief and cry and feel sadness, right? When he was pushing it under the rug for 10, 20 years, according to the vignette. OCPD, obsessive compulsive personality disorder. So I'll try to derive which which assessment is the best for clients with OCPD. And the options are test of variables of attention, the behavioral assessment system for children, BASC, parental rating scale, Connor's rating scale for ADHD, and Vanderbilt assessment scales. And I think this client is an adult. So I'll read the answer now. Test of variables of attention, TOVA, is a computerized test that can be used to assess adults and children for both inattentive and hyperactive tests of attention deficit disorder. The behavioral assessment system for children, BASC, parent rating scale, Connor's rating scale for ADHD, CRS, and Vanderbilt assessment scales, VAS, are rating scales testing for children only. And this vignette was for an adult. So for these assessments, you just got to know them. You got to know what ages they test for. So I hope that kind of gives you some type of guidance, because the assessments, you got to know what they are sometimes by initial only, in the age group that they or the demographic that they're for. So the answer is test of variables of attention, or TOVA, T-O-V-A. But that one tests for adults and children. Here's a fact for you about OCPD. Personality disorders tend to be lifelong, but treatments have shown that some personality disorders, including OCPD, are able to be moderated with the correct therapy. In this case, the client has met some criteria for OCPD, though not all of the required criteria, so would be noted as demonstrating traits of OCPD. This makes it more likely that with work, the client can modify his behavior. So the client has been told that he is OCD. It will be helpful to clarify what the disorder is so he can understand he does not fit that into that category. Telling the client that men are diagnosed as twice as rate as women with OCPD may help him feel his OCPD trait diagnosis is not so rare in that he is abnormal, that he's not abnormal. Letting the client know that some of his behaviors may have been helpful for him in succeeding, and that is only when he becomes too focused on them that they may be problematic. So it's like, what do you tell the question was like, what do you tell a client with OCPD? That you're going to have it for life? That men have it more than women? That some of his behaviors are helpful in succeeding? And so these are some of the things that you have to understand with these questions that are like, what is like the least helpful? What is the most helpful? And just reading the full question altogether. The greatest barrier for the client and for most people with OCPD is a lack of insight about their thoughts and behaviors. They frequently do not see these as issues and instead believe others as lazy, ungrateful, unmotivated, or incapable of following logical rules and schedules. Which of the following interventions would not be included in psychodynamic therapy aimed at increasing the client's level of insight and awareness? All right. A, content versus process. B, transference. C, identifying core beliefs. D, free association. Give you a section to think about that. The answer is C. Identifying core beliefs is a useful intervention in cognitive behavioral therapy, not psychodynamic therapy. So again, with the question, which of the following interventions would not be in psychodynamic therapy? So with these therapies, you don't have to know everything, but at least know what CBT, it's core beliefs, right? So, or at least have an awareness of these therapies. Identifying core beliefs is a useful intervention in CBT, not psychodynamic therapy. Psychodynamic therapy is unstructured and makes use of the relationship between the client and counselor, transference and countertransference. Free association to help the client and counselor explore how the conscious and unconscious are influencing the client, and content versus process, in which the counselor helps the client explore their communication at both conscious and unconscious levels and what is meant by their verbal or behavioral communication. Psychodynamic. Whew. Clients with OCPD focus more on logic and orderliness rather than emotions. Really important sentence. Clients with OCPD focus more on logic and orderliness rather than emotions. Just hyper-focus. Emotions and expressions of emotionality interfere with the rigidity of the OCPD client. You have to get the task done. Feelings are just not on the equation, like they're not on the table. I got to finish the task. Got to do it this way, got to finish it. The need to control oneself and environment requires the OCPD client to use logic rather than emotions, as the latter leaves the OCPD individual vulnerable to rejection if he or she does not respond with perfection. This can leave the individuals with OCPD appearing socially awkward, cold, and unfeeling about others' needs. Psychodynamic therapy helps the OCPD client identify, explore, and express their emotions through increasing self-awareness and insight. Individuals with OCPD do not focus on emotions over the end results of a task, and the individual would be more focused on perfection rather than completion. Criterion 2. Additionally, individuals with OCPD rarely delegate tasks to others, instead completing themselves unless the other agrees to do a task exactly how the individual with OCPD has instructed. Criterion 6. Warning the client that you will eventually behave in a way that upsets him is one of the most important things a therapist can do with a client with OCPD. So if you see a client has obsessive compulsive personality disorder, you're going to have to let them know up front. Hey, there's probably something I'm going to say or do that's going to piss you off because I'm a human and I'm flawed and I just do things incorrectly sometimes. And you have to let them know up front. The client's tolerance for lack of perfection in others will be triggered when at some point the counselor, like others in the client's life, will behave or say something that violates the client's rigid standards or expectations for perfection. Violating the client's expectation for perfection from the therapist is frequently the cause of OCPD clients to terminate counseling. Forewarning the client of this provides the opportunity to talk about how staying in the therapeutic relationship can help him learn to manage the conflict. Using a feeling wheel or list will not be helpful with the OCPD client because increasing his self-awareness and insight will be needed before he is able to begin working through emotions. Likewise, looking at and understanding others' perspectives may be attempted, but the client will eventually need to change his own perspectives of his ways will need to challenge his own perspectives of his way of being as the only right one, rather than focusing on others. Prolonged exposure is an effective treatment for OCD, but is not effective in treating OCPD. OCPD requires the client to gain insight into his rigid and inflexible nature if he wishes to make personality changes. Exploring his earliest memories of trying to be perfect will help him link his past experiences with his present thoughts and behaviors, which can help him develop greater insight and self-awareness. Exploring his earliest memories. That was the answer to the question. Exploring his earliest memories of trying to be perfect will help him link his past experiences with his present thoughts and behaviors, which can help him develop greater insight and self-awareness. Moving on to career counseling. Like 60% done, 70% done. We're almost done. Career counseling focuses on career decisions and choices, as well as any personal or mental health issue that impacts a client's career satisfaction or career decision making. Career counseling, therefore, does not focus only on exploring career and occupational choices. So, if a client is a breadwinner and they get fired from their job of being like an accountant, and they only went to an accounting because their dad had did it and their dad's dad did it and whatever, but they really have a heart for art, then, you're going to have to explore more than just career paths. You're going to have to explore, their core beliefs. You have to really kind of go there with them so that you can help them versus just saying, hey, man, let's just do something else. Whatever, who cares? Question. Which of the following would be the best tool to help the client find a good fit between her personality and a work environment? A. What color is your parachute? B. Strong's Interest Inventory, SII. C. Holland's Self-Directed Search, SDS. D. Savickas Career Style Interview, CSI. Give you time to think. The answer is Holland's Self-Directed Search. Holland's SDS is based on his theory of personality as it relates to career choice. His widely used theory and tests suggest that occupations and work environments have characteristics that appeal to particular personality types. By matching types, the counselor will be most likely to find an occupation and work environment that matches his personality. The book, What Color is Your Parachute, is a best-selling job hunting book, but will not help the client match her personality to an occupation or work environment. Again, the question was, which of the following would be the best tool to help the client find a good fit between her personality and a work environment? The book, What Color is Your Parachute, is a best-selling job hunting book, but will not help the client match her personality to an occupation or work environment. The SII, Strong's Interest Inventory, was developed as an interest inventory to help the test taker to explore their potential area of study, careers, and leisure interests. It focuses on one's work style, learning environment, team orientation, leadership style, and risk-taking. The CSI, Savika's Career Style Interview, is a structured interview based on Adlerian and constructivist theories that help the client resolve their career problems. It is not meant to match clients' personalities to work environments or occupations, but to help clients resolve problems that hinder them in their career. All right. The Holland's RIASEC types are realistic, investigative, artistic, social, enterprising, and conventional. I don't want to guarantee that it's going to be on the test, but it's just one of those things that I know people who miss the test by one question, and you don't want to miss it just because you didn't memorize Holland's RIASEC. I think about it like Rihanna, RIA, Rihanna, and wait a sec, SEC, RIASEC. It's like RIASEC. You got to do what you got to do to remember it. But not only remembering the correct order of the acronym, RIASEC, but what it stands for. R, realistic. I, investigative. A, artistic. S, social. E, enterprising. C, conventional. RIASEC, RIASEC, realistic, investigative, artistic, social, enterprising, conventional. The Occupational Outlook Handbook, or the OOH. Ooh, because some questions had the Book of Jobs of Occupations. It was just all these different ones. The only one that exists in reality is the Occupational Outlook Handbook, or OOH. Ooh, just try to remember that. I'm trying to help you remember that. Ooh. The Occupational Outlook Handbook, is published by the Bureau of Labor Statistics in the U.S. Department of Labor. You can actually look at that right now. If you Google the Occupational Outlook Handbook, it will pull up what I'm about to say now. It contains thousands of occupations and information about each that include work environment, job tasks, required training, salary, and growth projections, and advancement opportunities. It is updated every 2 years and is the most popular source used by career counselors. The OO is matched to Holland's RIASEC personality types, and each occupation is coded with a type. Holland's RIASEC, And what does RIASEC stand for? Realistic, investigative, artistic, social, enterprising, conventional. Moving on. Structuring is letting the client know what to expect from the counseling session. It is an important aspect of the counseling process as it helps to organize the session and keeps things on track. It can also help establish a rhythm for future sessions. Capping occurs when the counselor de-escalates the emotions of the client, when the client is starting to lose control. Proxemics is the study of the client's body language and movements to determine emotions, thoughts, and feelings. Focusing is nonverbal attention to the client's words, which can help the counselor to see things from the client's perspective and help determine next steps. That's just counselor skills information. There was no question that I have for that right now. Direct therapeutic exposure has been proven effective for those diagnosed with PTSD. By real life or imagined exposure of the feared stimuli, or in vivo, or imagined exposure of the feared stimuli, skills like relaxation training are taught to help control clients' reactions. Intermittent reinforcement or conditioning. Intermittent reinforcement and conditioning are used to reward behavior and would not be warranted here. Confrontation is a therapeutic technique that helps within the client when they are taking a realistic look at their actions or patterns. So the question was, which is the best effective treatment for clients with PTSD? And it's like direct exposure therapy is what it's known by, but sometimes the exam will just say things, or the practice exams will just say it in a more studious way. Direct therapeutic exposure, when it's just exposure therapy. You see what I'm saying? So you just have to be critical in your thinking of, what they're saying. So exposure therapy has been proven the most effective, or has been proven effective for those diagnosed with PTSD, be it real life or imagined. You can relaxation techniques help. Intermittent reinforcement and conditioning are used to reward behavior, but would not be warranted for someone in PTSD. Confrontation is a therapeutic technique that happens when the client happens within the client when they are taking a realistic look at their actions or patterns. But it's not something that it's not the same as therapeutic confrontation. All right. Which is the least effective for helping a client with PTSD? I'm just going to read the answer, but the answer is this first one. Anti-epileptic medication has not been proven effective to treat PTSD. SSRIs, selective serotonin reuptake inhibitors, and SNRIs, serotonin norepinephrine reuptake inhibitors, have been found to be effective for PTSD. Anger management skills can teach the client coping skills to manage his reactions. Pet therapy has also been found to be an effective form of intervention for combat veterans diagnosed with PTSD. Exercise also helps release endorphins, which can help the client combat irritability and aggression. So the question was, which is the least effective for helping a client with PTSD? And the answer was anti-epileptic medication. SSRIs or SNRIs help. Anger management skills help. Pet therapy helps. And exercise helps. But anti-epileptic medicine has not been proven effective to treat clients with PTSD. All of the following statements are true regarding counseling, except, all right, it is important for the counselor to prevent the heightening of emotions to point where they can be accomplished. I guess I that was the answer, but I highlighted except. I have it big and bold because it's one of those things where I'm reading the question and I just zoom through it and I don't think about that part, and that's the most important part of the question. So, all of the following statements are true regarding counseling, except it's important for the counselor to prevent the heightening of emotions to point where therapy cannot be accomplished. If the counselor feels that tension is escalating to the point of an argument, the role of the counselor is to bring the emotions and guide the couple to effective communication techniques. Additionally, it is to help the couple gain insight to the relationship patterns and to provide techniques to improve relationship functioning. So that was the answer. It's all the following except. By videotaping couple interactions and replaying this in sessions, couples gain more insight on how they appear to the other person. Other couples may find a more non-directive approach useful, where the focus is on listening to one another's and clarifying attention. Lastly, behavior therapy using positive reinforcement and rewarding behavior when one person in the couple does something that the other one finds positive may be effective. So I'm trying to think what was the one that wasn't great. Well, at least you know the ones that are. So all right. Persistent depressive disorder, dysthymia, in which one criterion is that the symptoms persist for at least 2 years. I said that already, but adjustment disorder is a possibility as an initial criteria in an emotional response to identifiable stressor. Okay, so I stand corrected. Adjustment disorder is at least 3 months. And earlier I said at least 1, but okay, so PTSD can occur within 3 months. but it's longer than 3 months, and that's PTSD. Whereas adjustment disorder is within the first 3 months. Got it. Okay, great. PDD, persistent depressive disorder and or dysthymia, in which one criterion is that the symptoms persist for at least 2 years. Adjustment disorder is a possibility as initial criteria is an emotional response to identifiable stressor within 3 months. Okay, adjustment disorder is within 3 months. Longer than that is not adjustment disorder. What about acute stress disorder then? Within a month. Acute distress disorder typically occurs within a month of experiencing a traumatic event. Okay. All right. Traumatic event within the month. Acute distress disorder. More than a month. Adjustment disorder. More than 3 months. PTSD. Got it. Everyone on the same page? All right, so let me make sure I digest that correctly. Acute stress disorder typically occurs within one month of experiencing a traumatic event. Symptoms can include intense fear, helplessness, flashbacks, nightmares, numbness, and avoidance of reminders related to the trauma. The condition is closely related to PTSD, with symptoms lasting longer than 4 weeks, potentially meeting the criteria for PTSD. Acute stress disorder was first classified as a mental health disorder in 1994, and now is part of the trauma and stress-related disorders. But adjustment disorder is within 3 months. Very, very interesting, but it doesn't have to have nightmares, I thought. Adjustment disorder. Okay, got it. All right. Erikson stages of development. So this one, there's 8 stages, but there's one that got added later by Erikson's wife. So who made stages of development? It's a man by the last name of Erikson. And I'll just read the stages now. Stage 1, trust versus mistrust. Infancy from birth to 18 months. Can I trust the people around me? Stage 2, autonomy versus shame and doubt. Toddlers from years 18 months to 3 years. They pick out their own clothes, they're dressing themselves, what toys they like, and potty training, basically. Stage 3, initiative versus guilt. Preschool years from 3 to 5. Am I good or bad? Stage 4, industry versus inferiority. Middle school years from ages 6 to 11. How can I be good or bad? And there's a picture of a kid raising their hand in class, Stage 5, identify versus confusion. Teen years from 12 to 18. Who am I? You might see this on exams, just because of the teenage years. Stage 6, intimacy versus isolation. Young adults years from 18 to 40. Will I be loved or will I be alone? Stage 7, generativity versus stagnation. Middle ages from 40 to 65. How can I contribute to the world? Stage 8, integrity versus despair. Older adulthood, 65 to death. Did I live a meaningful life? Well, those are the 8 that we know for the most part, but Erikson's wife made up a new one called immortality versus extinction, and that's for people over 75. I've lived a good life. They accept death with integrity and without fear. So ones that you might see on an exam are identity versus confusion. These are teens to 18. Intimacy versus isolation, 18 to 40. That one's kind of self-explanatory. Generativity versus stagnation, 40 to 65. How can I contribute to the world? Integrity versus despair. Integrity, something that lives up to itself, that lives up to its own name. Integrity versus despair. Did I live a meaningful life? And again, those are the 8 typical, but Erikson's wife made a 9th one, and that's immortality versus extinction for people over 75. I've lived a good life. Counselor skills. Okay, we're rounding this up. Counselor skills. The purpose of clarification is to make sure the counselor understands the situation correctly. Did you say that you wanted to buy a dress to look good or for your boyfriend? Or both? Reflection of feelings would focus on how something makes the client feel. Reflection of feelings. I think you understand that one. Confrontation is not a confrontation between the counselor and client and counselor. It occurs it occurs when the client through it occurs within the client through self-examination. I confront my clients, but that's not the skill here. It's like when they are confronting themselves, like, oh my God, like my drinking makes me spend, or spending makes me drink, It's their own confrontation within themselves. Open-ended questions do not give a yes or no answers. Very self-explanatory. Paraphrasing can be used to reiterate or clarify information. So what I'm hearing you say is, resilience is the capacity for adaptation after a significant event. Just that's not necessarily counselor skills, just in general. Resilience is the capacity for adaptation after a significant event. The amount of resilience one has can determine positive or negative outcomes in situations. Risk factors are things that increase the likelihood of negative outcomes. Plasticity is the ability for brain cells to change from various experiences. Dynamics are the behavioral and relationship patterns between people. Empathy is a counselor attribute in which the counselor puts themselves in the client's shoes to understand the issues within the client's view of the world and the cultural values. Attentiveness is being able to focus on the client and what they are saying in the present moment. Genuineness refers to the ability of the counselor to be their authentic self in session and not put on a facade. Observation is the ability for the counselor to pick up on nuances in the counseling session, such as nonverbal communication. Apathy is a lack of interest or concern. Countertransference occurs when something in the therapeutic relationship brings up feelings for the counselor due to unresolved needs or personal conflicts. For example, a counselor's dog died a month ago. A client's let's say it again. A counselor's dog died 3 months ago, and they were their everything. A client's dog died yesterday, and the client's dog dying brings up something in the counselor. That's countertransference. It brings up something in you, like something unresolved in you. And you might, and a lot of answers were like, talk to your supervisor or colleague, that kind of thing. It is important for the counselor to recognize this and bring it to a colleague or supervisor. It would not be appropriate to work this out in the client's session. You're not going to hash out your dead dog to a client whose dog just died. Like, that's not, it's all about them. It's not about you. Transference occurs when the client projects their feelings, desires, and drives onto the counselor. Don't you think this way? Everyone should just drink, right? I had a client say, like, who was high as hell in our session, which I learned after the fact, but he was like, doesn't everybody just want to be high? I was like, oh my God. But that's transference. So transference when they project on you, and you're not fazed by it, but countertransference is when you're fazed by it. You're like, oh my God, like that brought up something in me. Counselors must be culturally competent and be self-aware of any biases that he or she has. Biases occur naturally and can be addressed with a supervisor or colleague so they do not affect the therapeutic relationship. If the counselor cannot do this, it would be beneficial to the client to refer out, especially to someone who specializes in similar issues. It would not be appropriate to share this bias in session, as sharing would make the session about the counselor and not about the client. Unconditional positive regard is warmth and acceptance towards the client while not focusing on past transgressions. Empathic attunement is the ability to put oneself in the shoes of another. Having a non-judgmental stance is not judging in comparison to personal standards. Warmth and acceptance towards the client regardless of what the client says or does. All right. Moving on. There's a lot of counselor skills there. Client confidentiality and privacy rights should be discussed at intake. If the client is a minor, confidentiality and privacy rights apply. even when the parent or guardian wants to know what happened in the session. So, first session, probably, the parent or guardian's there. Second session, it's just you and the minor client. And afterwards, if the parent's like, what y'all talk about in session, you gotta honor confidentiality. Or one of the questions was like, you might want to have little Jimmy tell you what we talked about today versus me spilling the beans. Because I'm not getting fired for you, lady. Huh. Or sir. Or losing my license, I should say. Or both. A systemic counselor tries to look at the client within his or her system and not just individually. One way to use this is by using a genogram. If you don't know what a genogram is, I highly encourage you to Google that so you can know. It's basically just a family tree, but it's like a mental health family tree. In fact, easiest way to say it. Empty chair is Gestalt. Gestalt is empty chair. Moving on. So there's one question like, all these are techniques of CBT except, and it was like deep breathing exercises, empty chair, challenging core beliefs, behavioral modification, so empty chair, Gestalt. Gestalt, empty chair. There's 4 categories of bipolar disorder. Bipolar 1 disorder, one manic episode for 7 days, may or may not have depressive episode, increased energy, restlessness, euphoria, poor sleep, risky behavior. Bipolar 1. Bipolar 2, major depressive disorder, major depressive episode for a minimum of 2 weeks, one hypomanic episode, in which can be misdiagnosed as depression. Cyclothymic disorder, fluctuating low-level depressive symptoms with periods of mild mania for 2 years at least in adults and 1 year in children. Other specified and unspecified bipolar and related disorders. And that's just kind of like, it's like a diagnosing question when you'll get that. Mania is elation. It interferes with ADLs. It involves risky behavior, spending, sex, harmful behavior. It's not manic if you're under the influence of a drug. So, mania is just by itself when somebody is sober, so to speak. But it's not manic if somebody's on drugs. Hypomania is less severe than manic, but still different than their usual mood that people can notice. Hypomania. Depression is sadness, hopelessness, thoughts of suicide, change in eating and sleeping habits. So there's a little graph here, but I can explain this. So the categories are mania, hypomania, depression. Bipolar has mania, maybe hypomania, maybe depression. Bipolar 2, no mania, yes to hypomania, yes to depression. Cyclothymia, no mania, mild hypomania, not a full episode, and mild but not full depression. So I will say that again. Bipolar 1, yes to mania, maybe hypomania, maybe depression. Bipolar 2, no to mania, yes to hypomania, yes to depression. Cyclothymia, no to mania, mild hypomania, mild depression. Adverse childhood experiences, also known as ACEs, ACE, are negative experiences throughout the lifespan, such as a child abuse or caregiver mental illness, which can lead to toxic stress. The more ACEs a person experiences, the more likely they are to have mental health and physical complications later in life. Adverse childhood experiences, or ACEs. The focus in cognitive behavioral therapy is to demonstrate to the client their faulty core beliefs. It is short-term and directive. Adlerian therapy is longer term and looks at childhood experiences and family constellations. Behavioral therapy does not look at the causes of behavior, but focus on repeating positive behaviors and extinguishing negative behaviors. All right. Brief psychotic disorder equals at least one of the following: delusions, hallucinations, disorganized speech, disorganized catatonic behavior. It's greater than 1 day, but less than 1 month. Brief psychotic disorder. Schizophrenia equals hallucinations, delusions, disordered thinking, especially in episodes of psychosis without significant mood disturbances, greater than 6 months. Schizoaffective disorder equals symptoms of schizophrenia with mood disorder symptoms such as depression or mania. No evidence of decline in role function, 1 depressive or manic episode. Schizotypal personality disorder equals social anxiety, eccentric behavior, and cognitive distortions. Unlike schizophrenia, doesn't typically involve full-blown psychotic disorders. All right, moving on from that. The essential feature of schizotypal disorder is a pervasive pattern of social and interpersonal deficits marked by an acute discomfort with and reduced capacity for close relationships, as well as cognitive or perceptual distortions and eccentricities of behavior. The essential feature of schizotypal disorder is a pervasive pattern of social and interpersonal deficits marked by an acute discomfort with and reduced capacity for close relationships, as well by cognitive or perceptual distortions and eccentricities of behavior. So what was I reading earlier that has those? Like narcissism or BPD, like interpersonal deficits. But this, the difference is acute discomfort with and reduced capacity for close relationships, as well as cognitive or perceptual distortions. Something's just out of whack. And eccentricities of behavior, just little goo gaga things going on, you know? Delusions and hallucinations can be caused by substance use, so it's important to rule out physical causes first: substances, medical conditions, brain injuries, etc. Safety is top priority with actively psychotic clients. The duration and severity of symptoms helps to understand clients' present functioning and possible safety risks. Cognitive behavioral therapy has been proven effective for clients diagnosed with schizophrenia. One of the most important qualities that the counselor should have to establish is an effective therapeutic client relationship with the client is the ability to establish trust. Let me say that again. One of the most important qualities that the counselor should have to establish an effective therapeutic relationship with a client is the ability to establish trust. This is especially important with a client who is suffering from delusions and his hallucinations. They have to be able to trust you because they can't trust themselves or their own thoughts. Gender dysphoria is characterized by marked incongruence between one's expressed gender and assigned gender. Body dysmorphia disorder is a mental health condition that disrupts how you see and feel about your own body and appearance. You can be the picture of health, but you think you're fat. Whereas gender dysphoria is you don't like that you have boobs. Or whatever else downstairs. All right. Body dysmorphic disorder is a mental health condition that disrupts how you see and feel about your own body and appearance, not exclusive to gender. Transvestic disorder is characterized by sexual arousal from cross-dressing. There are so many paraphilic disorders. I am not going to go to any. Transvestic disorder is like the only common one you'll see that kind of goes with gender dysphoria. But there are so many paraphilic disorders. Like, I Googled it recently. There's a whole Wikipedia page of stuff from A to Z that I've never heard of. But you'll hear like frauderization and voyeurism and exhibitionism. Like, those are the common ones. But again, there's a list. Like, there's an A to Z list of paraphilic disorders. So I'll let you dive in on that on your own. All right. This is one of those, like, pay close attention to this, okay? Which of the following is a non-projective test that can be administered? So these days you hear people say, oh, you're just projecting your feelings on me. Like, so if somebody's a scammer and they hear something bad, they're saying like, oh, that sounds like a scam. Or you're such a scammer. That's somebody projecting on you, okay? So a projective test is something that where it's not just straight up facts. It's like you get to fill in the blank, so to speak. You project. So which of the following is a non-projective test that can be administered? Thematic apperception test, Rorschach, Achenbach tests, sentence completion tests. Which of the following is a non-projective test? And these are things you just got to know, apparently. The answer is the Achenbach, spelled Achenbach, Achenbach tests are a collection of question-based assessments from ages 1.5 to 90 and are not projective. Achenbach tests look at several areas of functioning. Projective tests use ambiguous stimuli, which are identified or completed by an individual and are said to bring forth unconscious feelings or desires. The thematic apperception test uses ambiguous scenes in which the individual tells a story of what they think is happening. The Rorschach test uses ink blots, in which the individual identifies what the object is. In the sentence completion test, a sentence stem is given which the individual completes. Your mom is a... and whatever you said just then is a projection. All right, moving on. Not feeling pain or having an outer body experience is called dissociation. Dissociation is the feeling that you are separated from yourself, which often happens when someone experiences a very painful or traumatic event. Displacement is a defense mechanism in which a negative emotion is redirected to a less threatening object. Defense mechanism in which a negative emotion is redirected to a less threatening object. Interesting. Projection is a defense mechanism in which feelings are placed onto another object or person. Hallucinations are experiences that are not real and are created by your mind. Crisis planning is an intervention that should be used immediately to address risk-taking behavior and aggression towards others and is helpful when an individual starts to decompensate. Decompensation is a term used in psychology to describe a state where an individual's previously effective coping mechanisms fail, resulting in a significant decline in mental health functioning. This breakdown can occur after the period of relative stability and is often triggered by stress, such as trauma, chronic stress, or exacerbation of an underlying mental health condition. Low cognitive functioning, which may be an indication of an intellectual developmental disorder. I'll say that again. Low cognitive functioning may be an indication of intellectual developmental disorder. Attention deficit hyperactivity disorder has symptoms of inattention or hyperactivity. Persistent depressive disorder, dysthymia, in which one criteria is that the symptoms persist for at least 2 years. Adjustment disorder has the initial criteria of an emotional response to an identified stressor within 3 months. There's a question that goes with that, but just giving the definitions is just easier to versus giving the vignette. I said this earlier in the video, but reactive attachment typically happens in children. Attachment theory is all about how you were raised. Separation anxiety disorder is characterized by excessive fear and anxiety concerning separation from whom the individual is attached. Signs of autism in children may include lack of interest in playing with other children and mood fluctuations. Reactive attachment disorder, or RAD, is a rare condition where children don't form emotional bonds with their caretakers. Reactive attachment disorder does not have cognitive and language delays. Individuals diagnosed with reactive attachment disorder and autism spectrum disorder may show cognitive and language delays as well as a range of intellectual functioning. However, Individuals diagnosed with autism spectrum disorder do not have a history of severe social neglect. Additionally, restrictive interests and repetitive behaviors can be seen with autism spectrum disorder, but not reactive attachment disorder. So that all that was basically to help you know how to diagnose one from the other, and how some are kind of blended, and so you just know the difference. Back to some assessments that you just got to know. Projective versus non-projective assessments. So again, projective is like you fill in the blank. Non-projective is just facts, data, answering the question. Like the BDI is non-projective. It's just begs depressive. You're just asking questions. I feel sad all the time. I feel a little sad sometimes. I'm not sad. I feel great. So it's not filling in the blank. You're just answering the question. But projective versus non-projective assessments. Projective, house tree person, measures the aspects of personality, including cognitive, emotional, and social functioning. But the kid has to draw it. They have to draw those three things. They have to draw a house, they have to draw a tree, and they have to draw a person. And then that measures the aspects of personality, including cognitive, emotional, and social functioning, depending on how big or small they draw the various items. Thematic apperception test, or the TAT. Ambiguous pictures of scenes. The subject describes what they see in the scene. Interpretation is used to determine current problems and functioning. Draw a family picture test. Determines the child's attitudes, fears, needs, maturity levels, stressors, gender tendencies, and self-perception in relation to the family, their family, and significant others. Sentence completion tests, 12 and older. Explores needs, inner conflicts, fantasies, attitudes, aspirations, adjustment difficulties, and sexual abuse in children and adolescents. Story STEM assessment profile, ages 4 to 11. Semi-projective, narrative-based measure. Non-projective, strengths and difficulties questionnaire, ages 3 to 16. Measures emotional symptoms, functioning, conduct problems, peer relationship problems, social behavior, and hyperactivities. Stanford Binet, spelled B-I-N-E-T. Intelligent tests, ages 2 years to adulthood. Just an FYI, just things you got to know. Okay, we're almost done, I guess. There may be times when a client may not want to use their real name. If they are not paying through insurance, this should be accommodated. A client should not be forced to use their legal name. Counselors must discuss payment during the informed consent process, as well as payment modalities, and inform clients that they may change at any time, if applicable. When establishing fees, there are many things for the counselor to consider, such as location and financial status of clients. If the counselor realizes that payment is causing a hardship, appropriate steps must be taken, such as referring out to lower fees. Counselors also ensure that they give back in providing services pro bono to the community, training for future counselors, or reducing fees. And all that is in the Code of Ethics series that I did. I've read the entire Code of Ethics, which is in this playlist. So go back and watch that. And speaking of ethics, ethical code. Oh my God, I can't read anymore. Ethical code B.2.A. Serious and foreseeable harm and legal. Oh my God. Okay, take 3. Ethical code B.2.A. Serious and foreseeable harm and legal requirement states that the general requirement that counselors keep information confidential does not apply when disclosure is required to protect clients or identified others from serious and foreseeable harm, and when legal requirements demand that confidential information must be revealed. Counselors consult with other professionals when in doubt as to the validity of an exception. And this particular client is a victim of human trafficking. So the question was asked, do you refer the client to a shelter or go to the police? And the answer is go to the police. When answering the question, I said go to a shelter because I was thinking about this current administration. Who knows what it's like in the future, but currently our administration, political administration is, deporting people left and right. And this particular client is a victim of human trafficking. They're from a foreign country. They came here with the promise of being like a housekeeper, making so much money, living fine. But it turned out to be just like an awful situation. And they're sleeping basically in a cot in a closet and have to eat different from the family, not paid anything at all. Racial slurs are given. And so the client is coming to you. They don't want to give their real name. They're paying in cash. They're anxious the whole time during the session. They keep looking at their watch. They're really in a frenzy due to their situation. And so, so that's why the whole code of ethics was just brought up, because, we have to be able to protect them. Serious and foreseeable harm and legal requirements states that the general requirement that counselors keep information confidential does not apply when disclosure is required to protect clients or identify others from serious or foreseeable harm, or when legal requirements demand that confidential information must be revealed. So, she's a victim of human trafficking. So you go to the authorities in that situation. I didn't know that, and now I do, and hopefully you do now. So you go to the police in that situation. Cultural awareness is understanding that someone's cultural experiences and views are unique and may differ from your own. Curiosity is being inquisitive about a different culture. Empathy, again, is trying to put yourself in the shoes of another. And inclusion is providing equal access or opportunities to others who may be marginalized. So the question is tell me about your experience coming to a new culture and going through what you did. The counseling is demonstrating an attribute of, and the answer is cultural awareness. Not curiosity, not empathy, not inclusion, but cultural awareness. Understanding someone's culture, experiences, and views are different from your own. Tell me about your experience coming into a new culture and going through what you did, after they explain that they're a victim of human trafficking. An effective treatment for anxiety is, and the answer in this case is benzodiazepines. But this is my own personal note that they're highly addictive. The body builds resistance. Discontinuation can cause withdrawal symptoms, anxiety, seizures, and tremors. But benzos are an effective treatment for anxiety. Okay. Panic disorder is characterized by recurrent panic attacks with symptoms such as sweating, trembling, nausea, dizziness, or derealization. Persistent worry about panic attacks and or maladaptive changes must be present for at least a month. If panic attacks are caused by separation from home or attachment figures, this would be separation anxiety disorder. Additionally, if symptoms are only precipitated by social situations, this is indicative of social anxiety disorder. So if you have a child client that seems standoffish during the intake, you ask open-ended questions. I'll just cut to the chase and just explain this situation. You ask open-ended questions. There's no do you want to tell me what's going on? Because they can just be like, no. And you're like, okay, well, what do I do now? So you ask open-ended questions. Tic disorders are characterized by the presence of motor and or vocal tics, absent of any known cause of such as a medical condition or substance abuse. So I'll say that again. Tic disorders are characterized by the presence of motor and or vocal tics, absence of any known cause such as a medical condition or substance disorder. So tics are movements, or you're somebody who does that at the end of most of their sentence, you know what I mean? That could be a tic. And vocal tics, nah, or maybe that's just silly and dumb, but just like an expression, yeah, I mean, or you know what I mean, is a common thing that people say, but it could be just something that's said out loud, kind of like Tourette's, I suppose. That's a whole nother disorder. Paroxysmal dyskinesis are involuntary movements, usually following normal motor activity, said to be caused by exertion or stress or fatigue. Paroxysmal dyskinesis. All right, so here's a vignette. totally different client. A lady comes into the ER thinking she's at a police station. Her temperature is high, so she has a fever, rapid heartbeat, and her breath smells foul. Her hands, lips, and tongue are trembling, and she's hallucinating, thinking that the nurse is Officer Connor. Which of the following can be ruled out based on the stated symptoms? Alcohol withdrawal, sedative, hypnotic, or anxiolytic withdrawal, ketoacidosis, psychosis. So they all could be like the answer, right? But the answer is ketoacidosis. Ketoacidosis is a diabetic complication in which the body overproduces ketones and may cause hallucinations. However, one of the symptoms of ketoacidosis is sweet-smelling breath. What's the first thing to assess with this client? The same client that's hallucinating in the ER thinking she's at the police station. What's the first thing to assess with this client? Any medical conditions? Any recent substances used? Family history of mental illness? Or a mental status exam? I'll let you think about that one. First thing to assess with this client. Medical conditions? Any recent substances used? Family history of mental illness? Mental status exam. The answer is, due to the physical symptoms of fever and rapid heartbeat, it's important to stabilize her health and look at any medical conditions first. So I always thought substance abuse first, like, make sure she's not on drugs or anything first. But she could have some type of like mental or physical issue that you don't know of. So physical symptoms first when it's this extreme. More assessments that you just got to know. Which of the following screening tools for substance abuse would not be appropriate for this client? And it only just gives the initials. The initials. CRAFT with 2 F's, CRAFT 2.0. TAPS, DAST-10, DAST-10, or the ANA. What do you think? What do you think the answer? What do you think? What do you think? What do you think? The answer is the CRAFT 2.0, CRAFFT 2.0. The CRAFT 2.0 is for children ages 12 to 18 and would not be appropriate for this client, as she's like an older woman in like her 40s. I didn't tell you that, so you wouldn't have known. The tobacco, alcohol, prescription medication, and other substance use brief screening tool, or TAPS, is useful for screening of aforementioned drugs. The drug abuse screening test, self-screen, or the DAST, takes 5 minutes to yield quick results. I actually used the DAST-10, so I was familiar with that. But not the other ones. The addiction neuroclinical assessment, or the ANA, measures behavior, brain imaging, and genetics for a comprehensive measure of the measure of the levels and origins of addiction. So if they're doing an MRI on the brain, I guess that would be helpful to know this one too. All right, more of the vignette. This client has dealt with family tragedy and has been drinking heavily since her early 20s. They will binge drink for days, won't remember a thing, and will experience delirious states for days until they crash and sleep for an elongated time. The memory deficit is a result of alcohol withdrawal, alcohol poisoning, psychosis, or sedative withdrawal. What do you think? What do you think? The memory deficit. The answer is, the client is showing signs of alcohol withdrawal as evidenced by disorientation of time and place, vivid hallucinations of fast-moving animals, and she thinks rats are everywhere, and perspiration, fever, and rapid heartbeat. Alcohol poisoning may cause amnesia or mental confusion and is accompanied by physical symptoms such as difficulty remaining conscious, just pass out, vomiting, seizure, trouble breathing, and slow heart rate. Psychosis and sedative withdrawal are ruled out since symptoms are caused by since her symptoms are caused by alcohol and not substances. So psychosis and sedative withdrawal are from substances. whereas this particular client is just for alcohol. Here's some neurology. You just got to know this stuff. The name of the activated system central to the neurochemical process underlying addiction is serotonin pathway, mesocortical limbic pathway, norepinephrine pathway, or none of the above. I chose none of the above because I was like, it doesn't say anything about dopamine, so none of the above. The answer is mesocortical limbic pathway. The mesocortical limbic pathway is sometimes called the pleasure pathway and essential to the release of dopamine and is activated by drugs. Serotonin pathway stabilizes our mood, feelings of well-being, and happiness. The norepinephrine pathway is activated during stressful events and causes fight or flight response. This particular client is dealing with alcohol abuse. But this question was just like a generic question. It didn't have anything to do with the client. It was just like so that's like one of those tricky things that you just have to be critical in your thinking, So the whole vignette was just about this client who drinks, nothing about drugs, but just drinks. But this question was specifically just asking like a neurology question, and you just gotta know the answer, apparently, for neurology. But just know the dopamine, when you think about addiction, think about dopamine. And if it doesn't specifically say dopamine, you just have to know mesocortical limbic. Limbic is a part of you that regulates your emotions. So addiction, I don't know, you'll just have to remember that one. Mesocortical limbic pathway is sometimes called the pleasure pathway and is central to the release of dopamine and is activated by drugs. Moving on. All right, these next two questions are very, you got to pay attention and you got to just know the answer. So I'll read the questions and I'll break them down. A physical cause of drug addiction is. A psychosocial cause of drug addiction is. Cool? A physical cause of drug addiction is expectations of social success, a person's biological makeup, failure of parental guidance, alcohol flush reaction. So when you think physical cause, think like biology. Expectations of social success, social, biopsychosocial, a person's biological makeup, failure of parental guidance, parental, social, alcohol flush reaction. The physical causes of drug addiction include the pleasurable feelings of drugs may cause, cravings, and genetic vulnerability, as well as exposure to substances, just being exposed to them. Genetic vulnerability, aka a person's biological makeup. Expectations of social success and failures of parental guidance are psychosocial causes of drug addiction. Alcohol flush reaction is a physical reaction to alcohol seen primarily in people of Asian descent, in which the body cannot break down the enzymes in alcohol. A physical cause of drug addiction is a person's biological makeup. A psychosocial cause of drug addiction is failures in parental guidance, genetics, exposure and substances in utero, drugs that stimulate brain-producing immediate pleasure. What's your answer? The answer is, children with parents who abuse drugs or alcohol may not have the proper guidance to avoid drugs or alcohol themselves. So the answer is failures in parental guidance. Other psychosocial causes include using drugs, alcohol to relieve tension in an expectation of or social norm of. Let me say it again. Other psychosocial causes include using drugs or alcohol to relieve tension and an expectation or social norm which portrays alcohol to loosen up or increase their popularity in social settings. Genetics, exposure to substances in utero, and the positive feelings drugs may give are the physical causes of addiction. So just things you just got to be aware of, Physical causes, think biological. Psychosocial causes, think the world around them. Cool? Moving on. A modality of treatment that is person-centered and focuses on the client through the stages of change is called. A modality of treatment that is person-centered and focus on helping the client through the stages of change is called. There's no multiple choice for this. It's just, I'm going to give you the answer. What's your answer? You got it? Motivational interviewing. MI uses unconditional positive regard and empathy to examine the client's motivation to change and helps them process through the stages of changes to get there. Moving on. Almost done. Last 4 or 5 points. Which of the following is not part of an assessment interview? Structured interview, past evaluations and assessments, unstructured interview, observations of behavior. The answer is past evaluations and assessments can be helpful in the overall clinical picture and can confirm information provided by the client, but can be gathered later. Past evaluations and assessments. When you hear it, it makes sense, right? When you're like, if you didn't know, you're just kind of like, ooh, what could it be? The assessment interview should include a structured interview. Like, so if you're doing the BDI, if you're doing the Beck's Depression Inventory, it's structured. You're asking the questions. An unstructured interview, which is more conversational and observation of behavior and nonverbal cues. So, there's so many times when I'm doing a structured interview, like the PHQ-9 or the BDI or the BAI or the DAS-10 or whatever, and the client will go on a tangent and talk about whatever. You want to roll with them. You don't want to just be like, come on, no, go back to the questions. No. Like, you kind of roll with them for a second, talk about that topic, talk about their feelings about that topic. If it really does open up a can of worms, go there with them. But then at some point, bring it back to the questions. And if you're running out of time and the whole conversation is unlocking this pivotal breakthrough, you do want to roll with that and go with them, and pick up the next time and finish the questions if it's that important. But I think you can kind of gauge that as a clinician to see. But again, I can be rigid, so I can be biased in that, and that I want to get back to the questions. But again, if they're having some breakthrough and unlocking something that they have never unlocked in 10, 20 years, it's important to roll with that with them, But so an assessment will include structured, unstructured, and just verbal cues like observational behavior, observations of behavior. All right. Which of the following statements about panic and anxiety is not accurate? In a panic attack, the symptoms develop abruptly. Anxiety does not have an abrupt onset. Anxiety symptoms are always intense. Panic attacks usually subside within 20 to 30 minutes. Not accurate. What's your answer? Anxiety symptoms are not always intense. They can have a range in severity and are typically mild. In addition, the onset is usually not abrupt. Panic attacks have an abrupt onset and usually subside within 20 to 30 minutes. To distinguish between the two, it is important to look at the brevity and intensity. Panic attacks can happen like that, and anxiety kind of is like more insidious. Generalized anxiety disorder includes symptoms of excessive worry, difficulty controlling the worry, as well as difficulty sleeping, poor concentration, and muscle tension. Panic attack is not a coded mental disorder, but is included in the DSM-5 as a specifier used to identify what are the symptoms of panic disorder. Agoraphobia is the intense fear of leaving the house. FYI, right? Almost done. Risk factors for generalized anxiety disorder include genetic loading. So this is the question. Risk factors for generalizing anxiety disorder include genetic loading, respiratory disturbance, childhood experiences of physical and sexual abuse, history of separation anxiety. Risk factors for generalized anxiety disorder include. The answer is 1/3 of the risk of developing generalized anxiety disorder is genetic loading. So, who says genetic loading? Nobody, right? But you have to be critical when reading these answers in the exam. They're very like just textbook. They're very clinical, right? So, direct therapeutic exposure, exposure therapy. So you just have to really, common therapists might just know it as exposure therapy, or you might tell your clients exposure therapy. But clinically, it might be direct therapeutic exposure. Conversely, or in this situation, genetic loading. And again, the answer, 1/3 of the risk of developing generalized anxiety disorder is genetic. The other 2/3 are a combination of temperamental and environmental factors. Respiratory disturbance is associated with panic disorder, as well as reports of negative childhood experiences such as physical and sexual abuse. There's no evidence that a history of separation anxiety can lead to generalized anxiety disorder later in life. Last two. The Counselor Code of Ethics state that bartering is not allowed. Counselors should discontinue therapy for those who are offering bartering. Bartering is acceptable. Counselors may barter under certain circumstances. What's your answer? And again, I did a whole video about the Code of Ethics, so go back and watch that. The answer is ACA Code of Ethics A.10.E. Bartering states that the counselors may only barter if the bartering does not result in exploitation or harm if the client requests it, and if such arrangements are an accepted practice among professionals in the community. There is no hard and fast rule that bartering is or isn't allowed. There must be careful considerations for each scenario. Additionally, a counselor should not dismiss the client solely due to the client asking this question. You're out! Get out of here, barterer! And last question. And the last of my tea. In determining the course of treatment, the counselor should first consider. Great question. And this is just for anything. This is for anything. In determining the course of treatment, the counselor should first consider what has worked in the past for similar clients. What treatment has been successful with the client thus far? What treatment would take the shortest amount of time because of the client's financial situation? A holistic view of the client. What's your answer? The answer is, in determining the course of treatment, it's important for the counselor to not look at just fragments of the clinical picture. By looking at the client's history, culture, and physical and mental health, an effective treatment plan can be more effectively established. Although what has worked in the past with similar cases can be helpful, each person is unique. In addition, although the client may have tried things in the past that didn't work, that does not mean they may not be successful in trying it again. Finally, putting a short time frame on a course of treatment because of monetary constraints is not ethical. Well, my friends, that has been quite the video. This is over 2 hours, almost 3 hours. Wow, I've been sitting here for 3 hours. Almost 3 hours. This has been quite the video, but it's a long, there's a lot of information to go over, and I really hope that this has been helpful for you guys. I am taking my exam in 48 hours, in less than 48 hours, so hopefully I can report back with great news. But I hope this helps. I hope that you can do your own research. Again, don't take this as full 100% law, but again, I have been studying for quite some time, and this is just information that I put together with my own study guide, and I hope this helps for you. I am not going to belabor this video anymore. I hope this works out well for you again. Best of luck to you, and you're going to do well as a future therapist.